So what is brain stimulation? At a very high level, it's the idea of using electrical stimulation to activate and induce neuroplasticity in a specific part of the brain. And by doing so, hopefully alleviating symptoms, whether that's neurological symptoms, psychiatric symptoms, seizures, depression, OCD, but this idea of injecting some level of current, whether it's magnetic stimulation or electrical stimulation, to a targeted spot in the brain and changing that circuitry. It's very different than the psychopharmacology approach. You give a medication and you're inducing a chemical change in the brain, and it's pretty non-specific. So it's hitting most of the brain. Here, we're coming at it from a very different approach, very focused, targeted way of stimulating the brain.
Hi, I'm Lauren Parsons.
And I'm Andy Jackson, and this is the ALWELLCO Podcast.
Dive deep with us as leading experts share their unique perspectives on topics such as recovery, sleep, movement, and the latest innovations in the space.
Well, Dr. Keller, or I believe it's Corey, welcome to the ALWELLCO Podcast, and thank you very much for joining us.
Thank you. It's an honor to be here.
Yeah, likewise. Just to get us started, for our audience, so most of our audience are predominantly professionals, so they cross fitness, wellness, science, athletes, coaches, etc. So it would be really useful if you could just tell us a little bit about you, your role, your job, a little bit about your journey to kick this off, please.
Yeah, happy to. Let's see, where to start. Grew up in northern Vermont, old farmhouse. My mom was a psychologist. My father was a psychiatrist. I think it taught me how to talk about my problems, but really went away from mental health as a result. In college, I studied engineering, so I double majored in electrical and biomedical engineering and took the classes I needed to for medical school. Got out of college, wasn't really sure what I wanted to do, either see patients in med school or go to grad school. Applied to a bunch of jobs and got a research assistant position at Mass General Hospital. This was in the epilepsy unit where they were taking invasive brain recordings in awake human patients. And it just sort of woke me up and got me really excited about neuroscience, really excited about medicine. So I ended up applying to the MD and PhD programs. So they had joint programs. This was at Albert Einstein College of Medicine, continuing that research. And then in my third year of medical school, you rotate through a bunch of specialties and came back to psychiatry and just found it absolutely fascinating. I really enjoyed talking to these patients and thinking about where in the brain these disorders are coming from. Someone who's severely depressed, extremely manic, extremely psychotic, what's going on in their brain and how do we come up with better treatments for it? In addition, we didn't know a ton in psychiatry, and that was really appealing to me as I think an engineer and researcher, where I really wanted to write a book as opposed to reading a really large, thick book. And then this space of brain stimulation came into psychiatry around the time I was interested in it. This idea of we can figure out a spot on the brain that is abnormal in mental health and change that brain region and those circuits attached to it and alleviate symptoms was really appealing from like a neuroscience, precision engineering background. So it was really exciting. Got me into psychiatry residency at Stanford, and I did a postdoc there, went into industry for a little bit, came back. And basically the last 5 years, I've been running a research lab here at Stanford. And about 2 days a week, I do clinical work at the VA with brain stimulation and ketamine treatments in veterans. And I'll stop there.
That's very cool. Very cool. Well, it's probably actually useful for me, I think, probably give you a little bit of background on me, which is why I'm so excited about this. So I am an ex football soccer player, multiple concussions, several years getting these blackouts, went and checked heart, MRIs, all sorts of different things. Just by luck, found out I had AFib. Thought that was the problem, thought it was the issue. Dad had had a stroke, went and had an ablation, kept getting the blackouts. So went and did a full sleep-deprived EEG in the hospital and came back and they found out I had focal epilepsy in the front of my brain. So let's not get into it too much right at the moment, but since then I've been doing neurofeedback training several times a week that I go. So it'd be very interesting to get into this. So what's a great place to start in plain language then is, and it really was strange to me when people told me about it, what is brain stimulation? So for example, via techniques like transcranial magnetic stimulation, TMS, etc. What is it?
Yeah, It's a great question, and thank you for sharing your story. I'm excited to dive in and hear more and expand upon it. So, what is brain stimulation? At a very high level, it's the idea of using electrical stimulation to activate and induce neuroplasticity in a specific part of the brain. And by doing so, hopefully alleviating symptoms, whether that's neurological symptoms, psychiatric symptoms, seizures, depression, OCD, but this idea of injecting some level of current, whether it's magnetic stimulation or electrical stimulation, to a targeted spot in the brain and changing that circuitry. It's very different than the psychopharmacology approach. You give a medication and you're inducing a chemical change in the brain, and it's pretty non-specific. So it's hitting most of the brain. Here, we're coming at it from a very different approach, very focused, targeted way of stimulating the brain.
That brings up a question straight away because I went through the traditional neuro, and they have me on lamotrigine to help with the seizures. I'll just give you a couple of snippets. We don't have to get too deep yet. They wanted to give me 200 milligrams because they said the study started at that. I'm belligerent and Scottish. So I said, how about I start on 25 milligrams once a day and we'll see what happens. And my seizures stopped. And the blackout stopped. So I never went any further. I had my review, about a month ago? And they said, Andy, it only lasts 12 hours. You probably should start taking it at night because you could be having seizures at night that will eventually affect daytime. So I did. My HRV, which I measure every day, halved when I started taking it at night. So I am no longer taking it at night, and my HRV has gone back to normal. So it's quite interesting that you talk about the chemical, electrical differences because I'm actually doing both. So it'd be quite fascinating. So techniques like this TMS, why, for example, does that matter in things like, forget my problems at the moment, but in things like mental health care?
Why do we care about brain stimulation?
Yeah.
Medications have been around for a long period of time and are very effective for some people. They also come with a lot of side effects, right? You are giving a medication and that's sort of bathing both your brain and your body in those receptors. And that comes with a lot of side effects. When it works really well. And, these generic medications can be cheap and can be distributed. Your primary care physician can distribute them. And if it works well, it works well. Sometimes it works and then that response goes away. So at some point, a small proportion of the population, usually between a third to a half, develop medication resistant psychiatric disorders. That is, either the side effects are too bad or they're just not responsive to the medications and they need something else. This represents a different mechanism of action, a different type of treatment that can be beneficial for some of those individuals.
What motivated you to focus on treatment-resistant depression and neuroengineering approaches rather than the more standard psychiatric treatments like we've just been, briefly talking about?
Yeah, I think a lot of it was just my neuroengineering background.
Okay.
My background in brain stimulation in epilepsy from graduate school, that it was just a perfect mix. The psychopharmacology can be effective, but I'm not a basic biologist. I'm not going to be the person who develops the next molecule to go into the brain and affect the brain. I care about the precision of where are we stimulating, how are we measuring those changes. So it helped develop some tools using EEG and other measures to measure the brain's response to stimulation. And that's a little bit easier to measure than if you were going to give a medication. So some of it was just sort of right fit with my skill sets and my interest level. And medication-resistant depression was where brain stimulation was FDA cleared for. So for the last 20 years, it's been cleared for those that fail medications. Most of that is from a cost and access point of view, that these devices are quite large, access is small, and insurance ended up covering it for those who have failed a few antidepressant medications first.
Okay, makes sense. Would you mind describing the current state of brain stimulation therapies, what they can do well today, maybe what their limitations are as well?
Yeah, and focused on depression for the most part.
Okay.
So what they do well, when it works really well. So for these patients with medication-resistant depression, when we apply the treatment, I usually say about a third of our patients that come in with really bad depression leave with no depression. It can wipe out brain fog, trouble concentrating, trouble sleeping, you know, improved energy, mood. Um, so what it does well is delivering a different mechanism of action and treatment for these patients. What it doesn't do well, and the issues right now, is it costs a lot. Um, Access to care is a big issue. The treatment course usually is once a day for 6 weeks, and that once a day used to be 40 minutes of treatment. So you come into a clinic, and there weren't that many clinics around the country. You'd have to drive every day for a 40-minute treatment every day for 6 weeks. And that's pretty prohibitive for a lot of
Yeah.
We've recently changed that 40-minute treatment down to a 3-minute treatment protocol and shown that it's just as clinically effective. Nolan Williams and other colleagues at Stanford have developed a new treatment that is just a 1-week treatment, so you can fit all treatment courses within 5 days, and that definitely increases access to care. And most recently, there's a paper that just came out that still under peer review, but it was a single day of treatment, and they delivered all 20 treatments in a single day.
Wow.
And you can imagine that changes the game in terms of the cost for that individual and the ability to drive or fly for that single day of treatment. You almost think of it more as a surgery than a 6-week treatment course. The personalization piece is still far from ideal, and I'm happy to dive into that, but that's the other piece.
Yeah. So, lots of people listening to this will be hearing about TMS or, neuromodulation. They may feel excited, but very cautious about it. So, are there common myths or misunderstandings that you encounter, um, you know, regarding brain stimulation in psychiatry?
Most common misconception I get is questions around, is it like One Flew Over the Cuckoo's Nest? That is probably the most commonly cited movie around brain stimulation.
Mhm.
Yeah.
So it's worth saying One Flew Over the Cuckoo's Nest was electroconvulsive therapy, which is a different form of brain stimulation. And in the 60s was performed very differently than it is today. So this was to induce a seizure without a paralytic to stop your muscles in your body seizing. And so it really, I think, set psychiatry back a lot. TMS is very different. TMS is an outpatient procedure. There's no anesthesia, there's no IV, there's no seizure. You can talk and see and hear throughout the treatment. It's a 3-minute treatment. You walk out of that room right afterwards. So it's very different. That's probably the biggest misconception.
Very interesting. So, how do you see this personalized brain stimulation offering, or differing from a one size fit all approach?
Yeah, so there's lots of different directions here, which I'm really excited about. Treatment is typically applied. It's an electromagnet around this size. You sit in a chair. It's applied to the left prefrontal part of your head, right next to it, and it sends these magnetic pulses in that get into your skull and induce the neurons to fire. That's typically how it's applied. And it's applied to a spot on your skull. It has nothing to do with your actual brain. We actually don't take pictures of your brain to figure out exactly where it should go, which you would think needs to be improved. So that's one thing, is can we take a picture of your brain either with MRI or functional MRI and identify the connections in your brain to figure out exactly where we should target with TMS? Then there's the how do you deliver it? So TMS is a tool that can be applied in any frequency, intensity, location on the brain. There's a million different stimulation parameters or protocols. And we just used one of them because it was FDA cleared, 10 years ago. So how do we test out those million stimulation parameters to figure out what's best for that individual at that time? Brain state is a huge issue that is never really addressed. So patients come into the clinic and they stare at the wall. And we know from basic neuroscience that you need to activate those brain circuits in order to induce the most neuroplasticity. And so putting that patient in the right brain state is a piece of personalization that we're really excited about in the lab that is not in the clinic yet. And then how do we actually measure neuroplasticity during the treatment course? So right now you do your 6 weeks of treatment, you say, how are you feeling today? And you hope that it was right. It's called open label. You're not adjusting the treatment for the most part during the treatment course. If we could come up with measures or biomarkers that actually measure the amount of neuroplasticity every day or every week, you could actually adjust how you would apply the stimulation based on if you're inducing that neuroplasticity in that right direction. So that closed loop, adaptive aspect of the treatment we're working towards.
I've read that one of your goals is to identify biomarkers in the brain to predict the response to TMS versus other neuromodulation therapies. So, could you walk us through, firstly, what does that mean? And then what kind of signals are you looking for? How do you measure them? Why do they matter?
It's a great question. So one of the biggest issues with not being able to measure in the brain during treatment, right? We can't track neuroplasticity.
Yeah.
We want to be able to do that. And the whole idea of brain stimulation treatment is you're inducing lots of neuroplasticity in very specific brain circuits, and then your depression gets better. We haven't put that link together. And so if you take basic neuroscience or even in the motor system, there are measures of excitability using EEG or using invasive EEG that you can use to track neuroplasticity. These changes in excitability you can monitor over time. But in the prefrontal cortex, where we're really interested in areas involved in mood and emotion regulation, we don't have those. So we pair not TMS treatment, but now just single pulses of TMS. So we kind of ping the brain, kind of like sonar, and then measure the brain's response within about 50 milliseconds using EEG to just say, how responsive is that part of the brain right now? And that's a measure of prefrontal excitability that we've sort of developed and tried to refine, that we think in watching the change in the amount of prefrontal excitability, we will be able to track eventually and predict where symptoms will get better and when symptoms will get better. So there's two pieces of it. There's a predictive biomarker aspect of it, which is at baseline when you walk into the doctor's office, could you measure how much excitability you have in your brain at that moment? And could that predict if you're going to respond to TMS treatment or not? And then during treatment, can we actually track the amount of changes in prefrontal excitability? And are we moving in the right direction? Is this treatment changing that circuit? And will enough of that change then make someone feel happier and better from a depressive point of view? So there's a couple different types of biomarkers that if we had those tools in our toolbox, we could bring that into the clinic and I think have a much more effective and personalized treatment.
Okay. So from a depressive state of mind or state of view, it's the excitability that you're able to get back. How do you know what's good or what's not good? Is it just more excitability versus less?
Yeah, it's a great question. So a number of studies, and we're still doing these studies, but if we can track how someone's symptoms get better over time as a function of treatment and track their excitability over time and show that they are related, right? We could have, that's how you relate the brain responsiveness to the symptoms.
Okay.
Well, that isn't fully proven out, and that's part of what our lab is doing. There are some small studies that show that the amount of plasticity that you induce in the brain does relate to how much you get better with TMS, but that's not definitive yet. So we're working on that.
Okay. That makes more sense. Yeah. So I also read that your lab is combining invasive and non-invasive methods. Could you explain maybe how that works in practice and maybe, for example, when invasive methods are used and what that means for the patient and how it's safely done?
Yeah, would love to. So the biggest issue when you track these measures of, let's say, prefrontal excitability outside the brain, anything outside the brain, whether it's fMRI or EEG in neuroscience, the issue is you don't know exactly where those signals came from inside the brain. You don't know exactly what's signal and what's noise. And so you can kind of estimate and infer, but what you really need is simultaneous measurements outside the brain and inside the brain to like have that ground truth and say, how much do these relate? What signal, what's noise, where in the brain are these signals coming from? So we've been able to leverage a situation in the hospital in which these patients with epilepsy, and this is not depression, but where they failed multiple medications and they come in and the neurosurgeon implants about 300 electrodes into that brain to try to monitor where their seizures are coming from. And then it can actually, if that part of the brain is not involved in language and movement, they can actually cut out that part of the brain and patients can be seizure free. This is sort of last resort, very invasive approach. But during that time, we measure inside the brain and outside the brain, and we can do research studies to study how TMS gets into the brain and what it looks like outside the brain. So simultaneous recordings, and we can apply single pulses and a 3-minute session of TMS and measure those simultaneous recordings to say, when we measure prefrontal excitability, when we only have non-invasive recordings, what does that actually represent inside the brain? So that's really important to us to understand the mechanism of what these signals really represent.
And is that what I saw on the news last week from London? That I think it was one of the London hospitals had someone's brain cut open and they were making them play the clarinet at the same time. I don't know if you saw that on the news last week. Is that what they were doing?
It's the same approach. So there are times in the operating room where they have an awake craniotomy or they have the patient remain awake to say things that when you stimulate certain parts of the brain, they will say how they feel or say what's happening in their brain. And so, yeah, that's part of it. Often they're in the hospital for about 7 days outside of the operating room. And so it's a less invasive space, and we can do some research there if they consent to it.
It was kind of incredible that they had the brain open and they were playing the clarinet and stuff as they were
Yeah.
Yeah, I mean, it is amazing the amount that we've learned in human neuroscience from these patients that consent to doing research and doing science is pretty amazing.
Now, obviously, don't name names or anything, but can you give us like a case example of, a really illustrative story of how brain stimulation was kind of optimized and personalized, and then it resulted in, some sort of meaningful change?
Yeah. And I would say, the work in the lab, translating that to the clinic or clinical trials, we're still many years away from some of those newer tools getting implemented in the clinic. But I think the treatment that Nolan Williams developed, which is the SAINT therapy, this is a personalized treatment that uses imaging to guide exactly where to stimulate. We had a firefighter that really couldn't get out of bed, suffering from horrible depression, came into the clinic, got this targeted treatment, and within 3 days, just depression was completely gone. Like
Wow.
he was out of bed. He was tons of energy, really happy, and it was pretty profound. Now, which part of that treatment? That was where we packed all the treatments into a week and did the targeting. Which piece of that made him better? We're still trying to figure that out, but the combination was really powerful.
Wow.
I mean, I could kind of share that. I was just saying to Lauren before we started. So I go and do something called neurofeedback. They put electrodes on my head. I put headphones on. I'm watching a screen. I'm being stimulated, and there are all these sounds that are rewarding my brain and etc. So before I dive into it, might be a good idea to get somebody like you to explain what am I actually doing.
Yeah. I think of neurofeedback, which is a really exciting space that's been around for a while, but it's not brain stimulation. We're not injecting current into the brain, but we're trying to activate parts of the brain in a very naturalistic manner, right? And in some ways, you're trying to induce neuroplasticity by looking at pictures and seeing sounds and trying to turn those parts of the brain on and strengthen those connections, but without that current injection.
Okay, that's a good
It's more
way of
naturalistic,
explaining
it's
it.
softer, but it's also potentially harder to do that um, because it's so naturalistic. What you're trying to do is there's lots of different forms of neurofeedback, but some have you take a part of the brain using the scalp EEG. They try to measure the neural signals from a specific part of the brain and have you see that. And so you can train your brain to turn up or turn down those signals, which is pretty cool, either with various pictures, or you see a bar. And so you can actually learn what it is that can modulate your own brain activity. I think, which is pretty cool. So they do this in fMRI. They try to help you learn about your amygdala and your fear response, and you can see it, and you can see which sort of behavioral steps could turn that down, or certain cognitive training and attention, or lots of different things. So it's an exciting space. It's I'd say in parallel or related to brain stimulation, but in a naturalistic fashion.
Just really quickly before, I know Andy has a question for you here, but just really quick, you said neuroplasticity a few times now, and the very limited knowledge and education I have in neuroplasticity is, you hear this over and over, it's, neurons that fire together, wire together. And so that example that you gave of the firefighter with depression, how do we know? And I guess the answer is we don't know which treatment worked, but from a neuroplasticity perspective, did he have enough reps for it to be long lasting? Right? I mean, because what I hear is more is more is more, right? And then that connection is very solid. So what can you tell us about that piece of it?
Yeah, it's a great question. We don't know which parts of those treatments worked.
Right.
I really think of it like working out, right? You need a certain number of reps with a certain number of space between, and your muscles will build up. How long you need to work out, and what that looks like, it's not super clear. And so this individual received 50 total treatments of TMS, which was a really actually long course of TMS compared to your standard 6 weeks treatment. That's a once a day treatment. So that was only 30 total treatments. The number of pulses within those 3 minutes, it was actually more pulses than you normally get.
Okay.
It's actually a really large dose of TMS just in 3 days.
Okay.
So whether that's helpful, whether that reverses the effect eventually if you get too many doses or in too small amount of time, you can imagine if you're at the gym and you don't take that rest, right, you could actually negate any sort of advance in your bodybuilding that you got. So I think figuring out that exact timing, that exact number of pulses, that exact target, all those things, we have a lot to do, but I think we're making progress.
I mean, there were two things that you said when we were chatting about it that reminds me of when I go and have the treatment. So I said to Lauren, if I could do it every day, I'd do it every day because I am so focused after the training. Super focused, not distracted at all. And they, again, I'm taking that their expertise is solid, is that they're targeting two things. I came in with, obviously I had some epileptic issues and it was affecting my short-term memory. I'd go to a restaurant and 2 weeks later, my wife would ask me, where do we go? And I'd have no idea. When I was actually having the fits, you and I could be talking and I'd go in like a 20-second wave where I could see your lips moving, but I wouldn't understand a word that you were saying and I couldn't actually talk myself. And then I'd come out of it after about 20 seconds. Now, I have to say the lamotrigine has fixed that particular issue. So I come out totally focused and stimulated, as a business guy. And, if I was giving this to CEOs, I'd say, start your day. If I'm an NFL quarterback, I'd go, start your day with this. You're going to be so fun. And I think Aaron Rodgers, the quarterback, does do this. I think he actually does this part of his training. What's quite fascinating, though, was that you said that people can learn how to, let's play with the system. And I actually agree with you. I can hear certain sounds and I can do different breathing, or I can focus on something and I can almost make that sound either go away or be exaggerated. And they have these little bars that show my alpha and my gamma, and they say you should be here for this and down for this, and your brain did this, and etc. But they always ask the same thing. They always ask, how do you feel afterwards? Do you feel sleepy? Do you feel tired? How's your sleep going, etc.? So taking all of that, and sorry, that was long, but if you take all of this, what are the next most promising brain stimulation technologies, closed loop systems, better targeting circuits, integration with what I'm talking about? What are you seeing from a clinical practice that could be next for people like me?
Yeah. I appreciate you sharing, and it just enforces how amazing the brain is, right? And how much we have to learn, and how I think these treatments, whether it's neurofeedback or brain stimulation, I think can just get better and better over time as we learn more and more. So where do we go from this? I guess I can chunk these into categories. If we just take TMS as a device that exists, um, there's the increased access to care. Let's get this 6-week chunky, really bulky treatment down into a single day and figure out how to refine that. I think that would be a huge advance. There's a portability piece. Companies are trying to make these smaller.
Well,
Can we send this out to a patient house and do telehealth and deliver the treatment in a safe manner? There
I
are
mean, sorry to interrupt, Craig, but should the neurofeedback clinics that are sprouting out, should they be doing this too?
Yeah, potentially. And there is a lot of overlap between neurofeedback clinics and TMS clinics. These psychiatric clinics that are set up for procedures, whether it's ketamine, neurofeedback, TMS, it's very different than a private practice psychiatry office that does medication management. So they're definitely thinking about these, and there is a lot of overlap. There are now vans both at the VA and in private practice that have TMS in the van. And so they can actually go to the patient's home and deliver the care.
Wow.
It's
Cool.
cool.
That's
So
cool.
that's just like an increased access to care. How do we get this device less bulky, that's less scientific? The scientific pieces are, how do we understand where TMS is hitting in the brain? And I'm pretty excited about that. Understanding the mechanism, I think, is just such a core piece that will help us give really important information to develop next generation technologies. Then there's what do all these stimulation parameters do? We only apply one treatment pattern, but there's a million. We need to understand that. And I think we're getting there. There's the closed loop aspect of it. So developing measures or biomarkers that we can monitor and then update that treatment, and how we actually do that. There's lots of different algorithms to do so. That's a big piece. The state dependence is a big piece that we talked about before. How do we put that brain into a certain state, whether it's with neurofeedback or psychotherapy or medication, or in our case, we're playing around with musical rhythms. Participants are napping and we're stimulating during sleep and during certain sleep states. So there's so much to learn there. And then there's different types of brain stimulation, right? There's focused ultrasound that you've probably heard of. There's temporal interference. There's lots of these technologies of how do we get information or signals into the brain to change the brain with really millimeter precision, but without needing surgery. So there's a lot, and pretty excited about it.
Yeah. For those listeners who maybe are exploring options, or maybe who, if they know someone who is, for either depression or OCD, what questions should they ask their provider about brain stimulation therapies?
That's a good question.
Yeah, it's a great question.
Yeah.
So the insurance landscape is kind of all over the place throughout the country. So it really depends on what insurance you're on and what their requirements are. Each insurance kind of requires a different number of antidepressants that you had to have failed before you actually get coverage of a TMS treatment. So asking them, is there TMS, nearby? In some rural areas, it may be 3 hours away. In other ones, it's 10 minutes away. Am I eligible for it? Usually for TMS for depression, it's have they failed enough antidepressant medications, and have they had any metal in their head or neck that doesn't allow them to get an MRI. That's actually the only real absolute contraindication to TMS. Those are the big questions. And
Okay.
if you're talking to a psychiatrist or even a primary care physician, they can put in those referrals and talk to someone like myself who will evaluate that person and make sure they're eligible. And that's the best next treatment for them. And then move forward from there.
Okay. Aside from what you just said, how else do you evaluate whether someone's a good candidate or not?
Yeah, unfortunately, a lot of it depends on access to care,
Okay.
insurance, if the patient wants it or not, right? That does matter a lot. There's lots of patients that don't want medications, that want a more naturalistic intervention where electrical signals are more naturalistic. Other people are scared about brain stimulation devices and would rather take a pill.
Mhm.
Um, Other people have lots of side effects to medication. So that does guide a lot of it. And then can they take the time off of work? Can they take the time off of caring for their kids? A lot of the things are logistical. At least at the VA, it gets a little bit easier, but we can usually be flexible and make it work with their schedule. I think in private practice, or if you have private insurance, it's a little bit trickier. But yeah, those are
Those
the
are
pieces
many.
we think about. There is, if they've had traumatic brain injury or brain abnormalities, that is something that we consult with the neurologist and talk with them about that. Um, and there are some other considerations, if they're abusing substances, what medications are they on? Does that reduce their risk of, increase their risk of seizures or not? So there are definitely pieces that we evaluate on top
Okay,
of just the, yeah.
sure. And how do you see brain stimulation therapies integrating with other things that are out there? So with the medication, with the psychotherapy, with the lifestyle, rather than replacing, right? Because it seems like a lot of
Yeah.
these things should maybe work together.
Well, that was going to be one of my questions, my lamotrigine and my neurofeedback and now TMS, how does this all link together?
Yeah, 100%. So right now, TMS or brain stimulation is an augmentation agent, which usually means you can stay on your medications. If you're seeing a therapist, you stay with your therapist and you get this add-on treatment. So it does work together with it, but understanding the complex interplay between medications and brain stimulation or psychotherapy and brain stimulation is something we don't do a great job at. So we know which medications increase the risk of seizures, but where those medications affect in the brain and how that might change how we deliver TMS treatment is not something that we know enough about what TMS is doing to be able to consider. So 100%, it really should be a coordinated effort across providers to say this person should get this psychotherapy at this time coupled with this medication and this TMS treatment. Like I would love to see that in the future.
And then kind of just a sidestep, but you said some things that made me think of it. Do you see TMS ever working or helping manage or helping not solve the issue, but recover those with with concussion? Because you said things about, seizure medication. So for instance, me, I had a pretty severe concussion in college. They put me on seizure medication. I had to medically withdraw from college. They put me through all the things they knew at the time from a concussion recovery standpoint. I had post-concussion syndrome for about a year, just kind of go down the list. And there's a lot of parallels to depression, right? Because it's just your brain is not functioning in the way that it should. They had me shut down to recover. So do you see any of these therapies working to help things like concussion as well?
Absolutely. I have a slide that I give that, TMS is FDA cleared for depression, for OCD, now for smoking cessation, and for migraines. And there's phase 2 and phase 3 clinical trials for every neurological and psychiatric disorder.
Okay.
Alcohol abuse, methamphetamine, epilepsy, Alzheimer's, Parkinson's, you go down the list. And slightly different brain targets sometimes, slightly different protocol, but the same TMS device are trying to tackle all of these disorders. So that would definitely include concussion or TBI or those sorts of things.
Hmm.
So I think we are making a lot of progress. We still need to learn a lot more about what TMS is doing to the brain. But I think 5 years from now, the landscape will look very different in terms of brain stimulation and FDA clearances for a large portion of these psychiatric and neurological disorders.
Interesting.
Yeah, I mean, I can go a little deeper. My mother has very terrible dementia, and obviously that's a big concern for me. And when I went to my neuro catch up last week, they said we're giving you the tough memory test this time, Andy, because we were trying to find out whether you've got early onset
Mm.
of this. Thankfully, I got 29 out of 30, and always fine. So you see this type of stimulation really helping that early on, or once someone's got dementia, preventative? How do you see this all working?
Yeah. First of all, I'm so sorry. It can be terrible, as you know. I see it as a tool that can treat any sort of brain abnormality or even improve brain function, right? It's a tool that you hit a spot on the brain, you induce neuroplasticity, and it either takes it from a deficit to normal or potentially from normal up. There's so much in this space about increasing attention, increasing cognition, that I think there probably is a space there for it too. Being in the medical practice, I'm really focused on the disorders. But whether it's Alzheimer's, it's a different part of the brain and it's a different circuit to target. But we should still be able to treat it with TMS once we figure out how to use it correctly and once we figure out how to personalize it. So it's a good question.
So in terms of risks, side effects that, people maybe underestimate when they hear brain stimulation, how do you discuss safety, ethics, realistic outcomes with patients?
Yeah. So if we start with benefits, I usually break it into a third, a third, a third. I say a third of patients who come in with really bad depression leave with no depression. A third who come in with really bad depression leave with half of their depression. And a third who come in with really bad depression do not get much of a clinical response. And we don't know right now, where we might with biomarkers, but we don't know right now who's going to respond or not. From a side effect point of view, it's actually pretty minimal, which is pretty exciting. Probably the worst part of it is the treatment itself. So it's a 3-minute treatment where we deliver 600 pulses in a very specific pattern. It's unlike anything you've ever felt. People have described it as a woodpecker pecking at your skull or snapping a rubber band 600 times.
I think maybe like
over the head with this stick. It's just very different. It's very uncomfortable. That gets easier over time as you habituate to that sensation. And it usually doesn't have people stop the treatment. It's only 3 minutes. Some people can have headaches. About 10% of patients that persist for 10 to 15 minutes and go away. That's actually pretty rare. It's a pretty high intensity, high frequency pulse. And so we give you earplugs just to avoid any ear damage, hearing damage. The biggest risk is seizures. And we always talk about it. So this is extremely rare. It was slightly more frequent back in the day with different protocols. Right now, I say our clinic's been open for 8 years. We've never seen a seizure. We treat 20 veterans, 20 treatments a day for our veterans. If a seizure were to happen, we say it's self-limited, which means it goes away on its own. It lasts less than 30 seconds. You don't develop epilepsy. You'll never have a seizure again, and we would have to stop treatment. Again, I say this, and right now the risk of a seizure is actually lower or at par with the risk of a seizure in an antidepressant medication, which is to say extremely low. There's also a very low risk that when you make anyone better from depression, you push them too high into a manic state in those with bipolar disorder. Again, that risk is very low, and we see these patients every single day. And so we can sort of catch if they're starting to elevate a little bit too much. The pretty positive side effect profile that usually doesn't push people away from the treatment.
Yes. Yeah, we've both done the neurofeedback, and it's the weirdest thing when you first do it. You have these tweeting and chirping and all these different sounds. And the first few times you do it, it feels kind of uncomfortable because you're not used to
it's overwhelming, I think.
It is. Yeah. And now I'm so used to it. I said, Lauren, I get a bit of a high when I come out of it.
Interesting.
So the world is moving towards wearables, home devices. Where do you see this going? Because obviously you talked about accessibility, you talked about cost, you talked about time, etc. How is your industry going to develop? Are we going to see an Apple Watch with a device on our head that we're controlling ourselves? What's likely to happen?
Yeah, well, those devices definitely exist that are take home, that aren't FDA cleared, but there are some promising treatments for depression. So these are things like transcranial direct current stimulation or transcranial alternating current stimulation. It's essentially a battery that you put 2 electrodes on your head and you can stimulate it at certain times. And so that's been around for a while. For depression, it's just not FDA cleared and usually not covered by insurance. I'd like to see things more portable and take home. The issue with TMS is just it's a big, heavy device. The hardware and infrastructure is hard. So, but we're definitely making some inroads. But I'd like to move towards a take-home device that has some telehealth aspect of it,
Mm.
potentially EEG monitoring for risks. There's new devices like AMPA Health has a camera built into the TMS machine, so you can actually see exactly where on the scalp you should be treating, and it only delivers treatment once it hits the right target. So there's some interesting innovations that I think will make it safer, but we still have a long ways to go in terms of getting it home. But even getting to the 1-day treatment, I think would be hugely beneficial. Um, Wearables and those sorts of things, whether it becomes something that, yeah, people can use at home or people can use at sleep, and it can deliver, 10 treatments in your sleep and you can be done. I think there's a lot of exciting space, but there's a lot of research to do and a lot of clinical trials to do to get there.
Yeah. I know there's a lot of hope for the future. Realistically, what would you see 5 to 10 years looking like, from now? Because of course, there's a lot of studies and things that need to take place.
Yeah. And 5 to 10 years in pushing the medical field forward is, it's hard to get a
A lot.
ton done.
I know, I
Um,
know.
but those things that I'd like to see are increasing access. So this becomes a 1-day treatment for everyone.
Yeah.
Um, some level of personalization, whether that's an MRI or some level of targeting for that person's individual brain circuits, including, I think, the state dependence in a really minimal way, even that if that's listening to some music, so we know exactly when we should be stimulating and we can um, align the neural oscillations with when you apply TMS. There's a lot of nice research in that space. And yeah, 5 to 10 years, that'd be pretty nice. I think we can get the measurement, the biomarker measurement into the clinic in 5 to 10 years. I don't know if we can develop novel treatments out of
Yeah.
those measurements, but definitely incorporating those in with a couple of EEGs with the same TMS device. We've already done that. And I think that could be more included in that database of how does your brain change and how do symptoms change, and the relationship between the two could definitely be built out and we could understand a lot more.
Cool. For those people who maybe aren't candidates today, or maybe just aren't ready for the TMS step, are there things they can do to prime their brain networks for change now, whether it be lifestyle, sleep, mindfulness? Are there tools out there or anything that you would recommend?
In order to prepare their brain for brain stimulation treatment,
Or just things they could do now to help advance themselves, without TMS?
yeah, yeah. I mean, I think lifestyle changes, eating right, sleeping right, socializing, like all these things for both your physical and mental health are extremely beneficial. Um, in terms of when you're getting TMS treatment, what you could do to your brain to prime it is a really interesting question that's still related to brain state. Are there certain medications that you could take? Should you exercise right before TMS? There's so many open-ended questions
Mm,
that needs further exploration, but certainly those lifestyle changes are, I think, critical to everyone and their health and happiness for sure.
I mean, it seems to me that everyone's talking about mental health nowadays. I don't know whether mental health has got worse. It's just the fact that social media is emphasizing it more. But everyone seems to be struggling. Well, not everyone, but lots of people seem to be struggling with depression, anxiety, some sort of treatment resistance, and maybe feeling discouraged. What would you say to them?
I would say you're definitely not alone. I think every one of us is struggling with something. As much as there has been an advance in talking about mental health and destigmatizing it, it's still hard to talk about, right? And it's still hard to ask about it in a really open and honest way. And so I think those pieces, we all need to get a little bit better at it to really ask, hey, how are you really doing? And really not accept some superficial answer as sort of ground truth. And Yeah, I think it's a combination of we have gotten better speaking about it and talking about it, and social media has definitely, played a role here for better or worse. Um, but really know that you're not alone. Know that there is help out there. There are treatments that work, and the more we all talk about it, the better.
So personally, what are you most excited about in your lab and your research now? What's coming next that you'd love our listeners to keep an eye on?
Yeah, I think two pieces. After a long time, we're just starting to figure out how TMS works. We're getting single neuron recordings in humans, which is like the most basic fundamental part of neuroscience, really deep in the brain too, while we're applying TMS. So we'll start to answer the questions: where does TMS go in the brain? How does TMS induce neuroplasticity? Where does it induce neuroplasticity? And really the near term, after 25 years, I think we'll start to get to that answer. And then the state dependence piece I'm really excited about. We haven't had the tools or those biomarkers to be able to push the brain around and see how that affects the neuroplastic effect of TMS. So the musical rhythms and some cognitive tasks, or having participants nap and stimulating during certain brain states, playing around with that aspect of the software of the brain while trying to induce different parts of neuroplasticity and being able to measure it. I think in terms of what could come in new treatments, I think we're definitely at the near term there, and it's pretty exciting.
Where can listeners learn more about your work and your lab?
That's a great question. Most of our information is on our website, which is
Okay,
precisionneuro.stanford.edu. There's publications, there's research projects, how to contact us. So I definitely start there.
cool.
Um, well, this has been fascinating, obviously personally, but also I think a lot of people are going to be really interested in this. I think there'll be a lot of specialists, and particularly some of the people who are in the neuro feedback space are going to be intrigued about this. They're all looking for new treatments. They're all looking for new ways to help, particularly depression and anxiety. Um, we always, though, at the end of our podcast, we like to wrap up with something that comes from our core values. Our core values are strength, kindness, and perspective. You've obviously shared a lot of great perspective here. Is there someone in your life that kind of embodies those values? Somebody who deeply influenced you, who mentored you, that you'd like to give a shout out to?
Yeah, I think I have two. One is Nolan Williams, who we tragically lost a few weeks ago. He was a colleague at Stanford who really invented the field of interventional psychiatry, the use of brain stimulation for psychiatry. Um, he I think his scientific achievements will just resonate for decades. And he was just always there. He was always there to help, whether it was patients or um, colleagues. And it's just a tragic, tragic loss. So he's one. And then I think my father, I think looking back on it, his kindness, strength, ability to balance work, life, everything has just been a role model throughout my life.